Good afternoon, everyone, and welcome to our session, Improving Patient Outcomes, Leveraging Clinical Data from HIEs. Today, we'll hear about two health information exchanges who are participating in the PCF data aggregation program and two of their participating PCF practices about how encounter notification services and diabetes hemoglobin A1C lab reports have empowered informed care coordination and management. Before we begin, I want to make a connection between today's presentation and relevant primary care strategies. The Primary Care First Care Delivery Report aggregates data from PCF practices and sheds light on care delivery trends across PCF. Looking at this data, we've learned that 44% of practices are working on hospital or emergency department notification changes. This means that over a third of you and your peers are updating how you receive or use hospital notifications. There has also been a 6.8% increase in the percentage of practices that follow up with a selective group of patients post-discharge. Looking at the trend lines on the right, you can see that the percentage of practices that follow up with all patients post-hospital discharge, represented in dark blue, has decreased from 2021 to 2023. Following the light blue line, you'll see that more and more practices are conducting outreach to specific patient groups in that same time frame. It's clear that PCF practices are changing the way they conduct hospital and ED discharge follow-up, with more and more of you making an effort to be intentional with that outreach and target specific patient groups. We know that HIEs play a significant role in the ability to receive comprehensive, accurate, and timely notifications to facilitate discharge follow-up. In today's session, you'll learn specific strategies for leveraging clinical data from HIEs, then hear PCF practices that have integrated ENS notifications and hemoglobin A1C reports into their workflows, along with patient success stories. We're hopeful that you'll take the processes you hear today and implement aspects of them within your own care teams to improve the care delivery processes. And now I will pass it over to James Lee, the PCF model co-lead and PCF data aggregation lead, to provide an overview of the PCF data aggregation program.
Thank you, Anita, and welcome, everyone. I'm excited to have all of you here to learn more about how HIEs are leveraging data aggregation to provide actionable insights to practices. At CMS, we understand that comprehensive data related to utilization patterns, cost of care, and quality outcomes that cover the continuum of care sites is valuable to practices because it empowers them to proactively manage patient care while simultaneously reducing practice burden. Given this understanding, we've partnered with HIEs to enable data aggregation for PCF practices so they have access to the data that they need to support practice transformation and improve patient outcomes. Currently, encounter notification services, an example of data aggregation in action, are being delivered to 307 PCF practices in Arkansas, Colorado, Florida, Nebraska, New York, Oklahoma, and Oregon, covering more than 197,000 patients. For those who aren't familiar with data aggregation, it is the process of compiling and curating data from a variety of sources into meaningful tools that can be used to transform patient care delivery. For example, as it relates to PCF, data from different care sites such as hospitals, specialty clinics, and labs are sent to HIEs who then compile and draw analytics from the data to make reports, send encounter notifications and alerts to practices related to their patients. This comprehensive information from across the care settings not only improves care coordination, but also reduces duplicative and unnecessary services. Through data aggregation, practices are able to participate in data-driven care delivery transformation while increasing their focus on patient-centered care. Thank you so much again for joining. I will pass it off to one of our HIE partners, Jennifer Fletcher from CyncHealth, to discuss their experience supporting practices to improve patient outcomes. Take it away, Jennifer.
Thanks, James. So as James mentioned, my name is Jennifer Fletcher. I am the Director of Health System Services at CyncHealth. I've actually spent the last 15 years of my career in healthcare operations. So when I took the job here at Cync, I did it actually with you in mind. I think one of the nice things is I lend a little bit of firsthand and frontline experience to some of the services and products that we offer. So I am going to tell you a little bit about CyncHealth before I get into some of the things we're going to talk about today. So CYNC is actually the state designated health information exchange for the state of Nebraska. It is our core product line. It allows all the providers that are connected with us to access medical information to make decisions on behalf of their patients. The second thing we're going to talk about, obviously, is the near real-time event notification services. So for those of you that don't know about that, we're going to talk a little bit about that here in the coming slides. I will also provide an overview of not only the notification services, but I'm going to introduce Jennie, and she works with Family Physicians Group out of Lincoln, Nebraska, and she's going to tell you a little bit more about how they use event notifications in their practice. So for those of you that may not know about what encounter notification services are, it is a near real-time notification alert that gets sent to providers. If you look at the pictorial slide below, for example, you'll see that if a patient comes into the emergency department, for example, maybe with chest pain, we receive that notification through an ADT message here at CyncHealth. And then at CyncHealth, then we take that message and we send it out to that attributed patient's primary care provider. And we're able to notify you that that patient has either been admitted, discharged, or transferred from a local hospital. So there's a lot of use cases. And I know Jennie, I'm excited for Jennie to share some of those with you, but some of those are, as we understand, without notifications, a provider, you yourself would never know about an admission to a hospital or an ER visit. Encounter notifications truly change the game. They allow you to be engaged with your patient. You can be more proactive in your care with them. And I think about, like, if you go back to the chest pain patient that we talked about, after you receive the notification in your office, it allows you to reach out to the hospital directly, and you can proactively share patient information with that hospital care team. Some of your patients might have psychosocial concerns or behavioral health concerns that really impact the care that they would be getting at that hospital. And by knowing that and that relevant information, you're able to more aptly assist with, that care provided at the hospital. The other thing that's nice about this is, should a patient need resources post-discharge from the hospital. So for example, a lot of our patients have social determinants of health that, need some, where they need extra assistance. This also allows you to start working on those processes before they even discharge. So as you continue to become more engaged with your patient and things like that, I love that the primary care team really gets the notifications and is able to assist while a patient isn't even in their office. So not only do the notifications alert PCPs to an admission, discharge, or transfer, but they also provide key clinical data that is really important for your office to know. So first, I do want to take a look at the notifications. So the top one that you're looking at right now is an email notification. When you look at the email notification, you'll recognize that it does not display any PHI, but instead directs the provider straight to the CyncHealth portal, where they would log in and see some information about why their patient has an event. The second notification that we offer is the fax or VPN printer notification. And you will see on that one that there's actually recognition that you are going to get patient PHI. The nice thing about that is, what you're also going to recognize in that notification is you're going to see that that patient was admitted to a Novo Regional Hospital. It includes some key clinical information that allows you as the primary care provider to understand, maybe what their chief complaint is or why they were admitted. For this particular patient, if you can see it in that screenshot, is this patient actually has a history of verbally aggressive behavior and some security events that might warrant a phone call to the hospital. You might actually be able to coordinate with that inpatient care team and manage that behavioral and medical care while the patient's in-house. The other thing I wanted to touch on a little bit was the ADT connectivity. So one of the questions we get a lot is, how do you know that that's my patient? And so one of the things that we do get is, we do get an attribution file from the PCP office, and that attribution file then matches up. And so when a patient of yours is admitted into the hospital, that's how the message is received. So I know personally I could provide various, studies or reasons that, event notifications are impactful. But I definitely want, that's the reason we invited Jennie. So I'm actually going to turn it over to Jennie from Family Physicians Group to talk a little bit about how it's impacted her practice. So it's yours.
Good morning. In Lincoln, Nebraska, it's still morning. I'm Jennie Powell, and I'm the office manager at Family Physicians Group. We're an independent clinic with a patient population of about 5,000 patients. Our patients range in age and health status, and we do see a significant number of Medicare beneficiaries. We're always looking for ways to improve care and address the challenges presented by these patients. One of the best examples I have that shows how that something we established and we worked this out and it works for everybody. We have a drop-in nurse administered blood pressure check. We offer to any of our patients that have hypertension. We found when you allow a patient just to stop in and just knowing they're only going to see the nurse and get their blood pressure checked by the nurse, it eliminates any of the stress that oftentimes a doctor's visit can result in a higher blood pressure reading. Those higher readings, in our opinion, can compromise the patient's confidence in their ability to control their blood pressure. So we're really proud of this practice because you can see the smile and the pride on their faces when they leave. And oftentimes as they leave and they're walking out, they give a thumbs up to the front office staff sitting there. And that just shows, I did it, I got it, my blood pressure was under control. When our patients do need to go to the hospital, it's really critical that we know about that, as soon as possible, right away. And when we started participating in the ENS with CyncHealth, we've been empowered to conduct proactive outreach to patient care teams, inpatient care teams, and also in order to coordinate immediate follow-up that patients need. Prior to receiving those notifications, we oftentimes were depending on our patients to let us know whether they were in a recent emergency room visit, or we had to go searching the records of the hospital websites. It seems like we missed a lot of follow-up, especially if that patient in the hospital wasn't able to or neglected to tell the hospital who their primary care doctor was. Now, not only do we get real-time notifications, which actually takes the burden off the patients, it kind of ignites our team to get going, to start acting what they need to do. I was trying to think of the best example. One of the most recent things that happened was we received a notification from a patient of ours that was in the emergency room in Florida. And our registered nurse was able to reach out to that patient, and she was just dumbfounded, like so grateful that we knew what was going on. When the notifications come into the clinic, they come to me, and I can see what type of notification they are. And I send them off and notify the appropriate registered nurse or the LPN of what needs to be done next. Then our nursing team can find the care contact to who's taking care of that patient, whether it's in the emergency room or as an inpatient, and they can coordinate information. A quick thing I remember happened was we received the notification, a patient was in the emergency room for chest pain. We were able to reach out and send them a copy of our most recent EKG we had done in office. And we knew who to call, we knew who to send that to. And that happened really quick, which that absolutely we would have never known anything about that had we not gotten that notification that they were there in the emergency room. Another success story we have a patient who was in the emergency room and in the end was admitted to the hospital. So she had instructions that were emergency room instructions upon discharge, but she also then had instructions that were inpatient discharge instructions. And when our registered nurse looked through that and noticed those notifications coming through, wait, she's leaving the ER. Oh, but she went to be the inpatient. And she kept track of that ER discharge information. Then, when that patient was discharged from the hospital, she was able to review her discharge instructions that the emergency room gave her and the discharge instructions that came as an inpatient, and she noticed some discrepancies. Without knowing so quickly about the emergency room visit and then the transfer to inpatient, I can't believe we would have ever been able to put that together without those notifications. And she noticed that this patient was going to go home and didn't understand that she should not be taking the 3 pain medications that came, 1 from the emergency room, 2 from the inpatient discharge. When our registered nurse did call her, she was so grateful too, to know she would have taken all 3 of those medicines without our intervention. That's it for me, unless there's any questions.
Thanks so much, Jenny, for sharing that. I did want to pass it over to Jennifer to cover just a few questions that we found in the chat. One was around whether or not encounter notification services can actually help prevent ED visits. And another was around whether the notifications are sent using the CMS rosters or the practices rosters. Jennifer, do you think you could cover those?
So for me, the notifications, we would not get anything prior, because it's the actual activity that generates the notification that it's happening. And then I guess with the roster from Medicare, I think that's maybe a question for Jen, because for us, we presented Jen with our entire patient population roster. We didn't stipulate any difference of who insurance or who participants were.
Yeah, that's correct. So as it relates to the patient attribution file, it is going to be the roster file for the actual clinic. So there are practices that don't participate with PCF and there's ones that do, and we accept the same file from both of them. So it is going to be the patient's roster file. The other question in regards to preventing future ED visits, I know Jenny actually talked about the fact that it can't necessarily prevent the first one, but Jenny told me actually about a story about where it can prevent future ones. So do you want to tell the story, or would you like me to?
No, go ahead.
Okay. So if I remember this right, it was that a baby had been seen in the ED overnight. In the morning, Jenny came in and recognized that they'd had an alert that a patient, had an event. And so the baby had received notification that they were in the ED. They called the patient or they called the baby's parents in the morning and just said, hey, I noticed that your kiddo was in over the evening. Is there anything we can do to help? And they said, actually, the temperature hasn't gone down, or they're not feeling any better. We're looking to go back to the ER. And they said, avoid the ER, come on in and we'll see you now. So it actually did prevent at least a second visit for that child to the ED.
Thanks so much.
Yeah.
And then the one other thing I just wanted to note with regards to that attribution question is that the aggregators who are participating in the PCF data aggregation do also use the CMS attribution rosters to supplement what the practices already send to the HIEs. So in cases where the clinic may not be including all of their attributed PCF beneficiaries, we use the CMS attribution roster to help fill those gaps to make sure that the notifications are as comprehensive as possible. Well, thank you again so much to Jennifer and Jenny for sharing with us how encounter notifications have improved care coordination. We are now going to turn it over to another one of our health information exchanges, Arkansas Share, who was going to talk about their hemoglobin A1C reports and how they are helping to empower practices with clinical information to help manage diabetes and prediabetes. Over to you, Justin.
Thanks so much, and great stuff. And we're going to kind of go off of what Jenny and Jen just presented, on hospital encounter notifications, and talk about the A1C. I'm Justin Villines. I'm the policy director here at Share. We're an Office of Health Information Technology, which is a division of the Arkansas Department of Health. So we're state government, and we oversee our statewide HIE. We've really been working on data aggregation since CPC Plus. and then moved to primary care first. So really working with CMS and getting attribution lists so we can notify our clinics. And it's been really successful. We have 100% participation of all primary care first practices within the state. So really excited about making sure that our clinics are getting notified on their Medicare beneficiaries. And then our practices also, some practices give us a full roster so we can track all patients regardless of insurance. We work with our notifications on a multi-payer level. So in Arkansas, our practices are very used to having their Medicare beneficiaries on with their Blue Cross or their Medicaid patients so that they can really truly be able to work those particular patients and engage their patients and the various teams. So really excited about that. We've been working in this since 2018. The multi-payer hospitalization reports really are highly utilized within the state. And our primary care first practices are dependent even from CPC Plus on us getting the roster from CMS and being able to notify them any event of whether they went to the emergency room or had an inpatient encounter. And that continued on through any practices that moved to primary care first. And really it's worked into their daily workflow, and they're very in tune to getting that multi-payer report so that they can really truly understand what their population is, what's happening, why they're going to the emergency room. It really puts them in the know when possibly they are not. And the good thing in Arkansas, we're statewide. So if a patient is, goes visits grandma in Northwest Arkansas or in Southeast Arkansas, and those hospitals are connected. So we have the mass majority, and so we're notifying them. So it's more of a comprehensive notification anywhere in the state. And, we have connections, to some sister states. So just like Jen kind of posed, a patient may go out of state for care and they may show up on their emergency, their hospitalization report. So, being connected to SHARE, being the statewide HIE, we're notifying on their hospitalization reports. It's notifying our practices on that real time. We're pushing those notifications via direct secure messaging. So it goes to the regular workflow. And this is really important when I speak on the A1C report, because this infrastructure has been built. And so the practices are very used to doing that or accessing those reports. But through our other payer relationships, and us notifying them on events, we have our patient portal that the practices can access the lab results or the discharge summary. But then also most practices are integrated so they can query SHARE and be able to bring those, what actually occurred at the different events. So building on the hospitalization reports, we got feedback from a lot of our practices. And in Arkansas, we have, a high percentage of patients that are diabetic or potentially borderline diabetic. And so there was an initiative that we kind of brought up and got feedback from the practices on, hey, can SHARE help us in tracking our A1Cs in an aggregate fashion? And so we, based on the list that we get from our Medicare beneficiaries from CMS, and we're able to look at A1Cs, not just if it happened in the walls of their clinic, but outside the walls from any participating facility. And we're able to then send this in an aggregate fashion. And really, this empowers our practices. It reduces the overall burden that they may try to, reach out and find, did they have an A1C? Is it reported? So they can proactively target certain patient populations, do targeted outreach and follow up. And Boss will talk about that in a moment, kind of that outreach. But I think really as we go through, we have some patients that are poor controlled, that need that is additional education, that additional assistance. So we're able to provide that information through all of our secure connections. So on the screen that you're looking at is a sample hemoglobin A1C report. And really, this is just, again, to support our practices. The method in which we send it is direct secure messaging. Our practices have been very used to getting our hospitalization reports that way. So this is an additional report that empowers them to see their patients that have an A1C on file and where. So it's not necessarily that they have a diagnosis of diabetes, right? They're diabetic, but they could be, 5%, 5.5%, close to 6. So it allows the practice to be able to see and target those individuals or those populations that are pre-diabetic potentially. So it just enhances the overall actionable steps that the practice may take. We're just empowering the nurses and the providers and the practice as a whole to take a more personalized approach, and just pushing that notification and those reports to them so they can be able to work that patient roster, that list, and reach out to those patients. We're a very rural state, so sometimes patients are leaving their community. And Voss will talk on that, about, the endocrinologist may be in a larger city here in Arkansas. So some of the initial findings, and this is, findings and feedback that we receive from practices when initiating the hemoglobin A1C initiative, was that 79.9% of the results were above 5.7%, representing pre-diabetic or diabetic potential patients. So there's a lot of opportunity that practices and the team can reach out and work with those patients on education or potential interventions. And then, over almost 60% of practices that we work with indicated that reports show patients with high A1C results that they weren't aware of. So that's pretty powerful. So then they can be able to work with them on certain interventions. And then again, 64.3% practices indicated and made them aware that other providers in that care team, that the patient may be visiting a specialist or another type of provider, ordered an A1C test and they weren't aware. But through the aggregate report, it allowed them to see that information, access it within Share via our patient portal or through our direct interface with their EMR. So again, really encouraging our practices to be proactive, but empowering them and reducing that overall burden. So I'm really excited that Voss is representing a practice in Mountain View, Arkansas, and we've worked together for many years, and they're doing some exciting work at Dr. Andy's family practice. So I'm going to turn it over to Voss to really paint that picture of how her practice is utilizing Share and the notifications and the A1C reports.
Thank you, Justin.
Thank you, Bob. I'll turn it to you.
Good morning, everyone. My name is Vas. I'm office manager at Dr. Andy's family practice. And today I'm here to share my experience with health information technology, Share Arkansas. Let me tell about my practice first. Our practice is in Mountain View, which is located in Northwest Arkansas, a rural town known for its natural beauty, but limited healthcare access. We operate as an independent practice with a single provider, serving around 2,500 patients across all age groups. We are a risk group 2 practice with 750 PCF patients. Our patient population primarily consists of elderly, retired, low income, and farming communities. Navigating healthcare in a rural setting presents unique challenges, but we deliver quality care to everyone who walks through our door. Despite being situated 40 miles away from the nearest specialty care facility, we are fortunate to have a critical care access facility. However, limited access to healthcare services remains a significant barrier. At our practice, we prioritize proactive disease management, believing in early detection and tailored treatment for each patient's unique needs. Our focus is on preventative care, education, and managing chronic condition. Today, here to share how we utilize SHARE to enhance patient care and outcome. I have been with SHARE for a long time, since CPC Initiative, CPC Plus, now ACO, PCF, and will continue being with them. Utilizing SHARE has significantly improved disease management in several ways. Number one, access to patient data. SHARE provides real-time alert information with the patient receives treatments outside of our practice, such as discharge from an inpatient facility. This allows us to coordinate with patients immediately and take timely intervention. Number two, care coordination. When it comes to managing disease, communication is key. SHARE enables us to share vital patient information, such as hospital discharge summaries and test results. This avoids duplicate testing, administrative processes like requesting and receiving medical records from other facilities. This saves time and resources, but also minimizes care gaps. Without SHARE, the lack of crucial patient data from other facilities and providers often results in care gaps, duplicate test procedures that leads unnecessary costs and inconvenience to patients. We heavily depend on two SHARE reports. Hospital report, which we always use that. We meet daily to review this report with our provider, contact patients, discuss their discharge plan, make necessary adjustments, and schedule follow-up appointments. Number two, A1C reports. We review and document these quarterly. On our first A1C report, we identified 2 patients with high A1C results who had missed their last few appointments, undergone tests elsewhere. By reaching out to them, we were able to re-engage them in their diabetic management. Highlights of these reports in addressing care gaps and medication management. Here are 2 cases I can share with SHARE being patient management. We had a patient, 67-year-old female, who presented severely ill and was admitted to our local hospital with a septic infection. Despite her deteriorating condition, we struggled to find a facility with available beds to transfer. After several hours of effort, we located a facility 4 hours away with a single available bed. With SHARE, we could monitor her hospital stay in real time, ensuring seamless coordination of care from admission to discharge and beyond. And on A1C case, on reviewing our A1C report, we identified a patient who hadn't visited us in 9 months and had been unresponsive to our attempts to contact. And we discovered he was admitted to a hospital 3.5 hours away with diabetic complication. With SHARE, we could track his hospitalization, coordinate his transfer to a rehab facility, and communicate and follow up care on his return home. So SHARE has been proven instrumental in enhancing our ability to deliver comprehensive, coordinated care to our patients, particularly rural health. Thank you.
Thanks so much, Boss and Justin, for sharing those. We're now going to take some time to answer questions from the audience, as well as a few questions that we have for the panel members here. So please go ahead and put any thoughts and questions into the chat. I'm going to start with one for Jennie Powell. You shared some very powerful patient stories about encounter notifications and how they allowed the providers to intervene on patient events that may have otherwise been unknown to your practice because they happened outside of your EHR. Can you talk a little bit about, what might have happened if you didn't have this information, or any additional information about how patient experience of care can help impact avoidable utilization?
So I think about that one case that I spoke of for just a bit, the one patient that left the emergency room and the hospital with 3 different pain medications. I mean, I think about if we didn't get the emergency room notification, if we just were looking at that hospital discharge, what could have happened if that patient would have taken those 3 pain medications together? I'm not sure. I'm a business person, not a medical person, but I imagine it would not have been a good thing, And so it's just also comparing the information we have and the fact that we just don't have to go digging for it anymore. It's just right there.
Thanks so much. I'm going to also ask one to Jennifer Fletcher. What has the response been from both the primary care providers and the hospital providers since implementing those encounter notifications? And has the use of payer attribution and CMS attribution helped practices be aware of patients that they're responsible for under the PCF model?
So to answer the first part of the question, Jennie is a testament. Family physicians group absolutely loves the notifications. I know that they do a lot of work reaching out to the hospital. So when they get those notifications, they can, talk to the ED doc, or they can talk to an inpatient hospitalist about, that particular patient's plan of care and what they need to do post-discharge. And then as far as following kind of that CMS attribution file, absolutely. I think it's one of those things where if those are the key focuses, I think it was in the slide that you, showed that we're actually now focusing on some specific patient types and demographics and diagnoses. I think it absolutely is going to help them capture how those patients are doing.
Great. And I see a related question in the chat about further elaborating on how these encounter notifications can help impact the quality measures in PCF. Maybe Justin or Jen want to take that one?
Sure, I can jump in here. I think, high utilization of the emergency room, like Voss said, where the HIE is there just to empower the practice, follow their patients, get the patient back in, have education moments. So hopefully we can prevent or assist in preventing unnecessary emergency room visits. But then also, them following up, there's many metrics on getting the patient back in after an inpatient stay, 7 to 10 days, so that, or they can, hopefully prevent a readmission from occurrence. But literature states that if a patient is followed up in that particular time, that they're less likely to go. And, in Arkansas, we're very rural, like Voss said. We have a patient that leaves their community and goes 3 hours away to a hospital. We want to empower that practice to get that notification so they can have as real time as possible interventions with that patient. So hopefully we have healthier outcomes. So I think, those real-time notifications, we're a firm believer here at Shared, being the statewide HIE for Arkansas, is pushing that information, empowering our practices and our care managers and our providers so that they know where their patients are going, so they can be able to manage their population, and hopefully they improve those outcomes and their metrics, and so we can have healthy Arkansans.
One thing, if I could add really quick to that, what the other thing about the notifications is you find out every procedure that might have been done during that inpatient stay. So it's a way we have found more than one colonoscopy that was completed for someone that went in for baby rectal bleeding. And we know then that we know the results, we can follow up and not try to repeat something that was already done in the hospital.
Yeah, just like the A1C that Voss said, the patient was not engaged for over 9 months. they showed up at an emergency room. They were on the A1C report that we pushed to them. They were able to follow up and offer those education moments to the patient. So hopefully, get them re-engaged into their own care.
Thanks so much. This is another one for Justin. So you talked a bit about multi-payer hospitalization reports as well as multi-payer hemoglobin A1C reports. Can you talk a little bit about the added importance of engaging payers and how that really impacts practices in terms of the data usage? And James, feel free to chime in on that one as well in terms of the importance of CMS partnering with other payers in this work.
Yeah, absolutely. We have a good relationship with most payers in Arkansas at the table as a neutral party in many instances. But really working with them, the payers, also the other payer private, including Arkansas Medicaid, tells us the PCP, the patient who's assigned where. And then we're able to include all those patients when they have events on that multi-payer report. So when VOS gets a report, it's not just that Medicare beneficiary that we get from the attribution for the primary care first program, but it's also for Arkansas Medicaid because she's in patient-centered medical home, which is a type of value-based program, or Blue Cross Blue Shield, or Centene or Ambetter of Arkansas. So those are patients that are attributed, and Dr. Andy is their PCP, and we're just empowering her through that multi-payer report. And so it assists the payers too, because we're able to notify them, hopefully reduce, unnecessarily emergency room visits and follow up after inpatient, so that VOS or any practice that may be in multiple value-based programs can meet many different initiatives, all within accessing that one report and working their patient population. And then with the payers too, we assist in, taking some burden away from them. I know we had a question on risk adjustment, but really, instead of the the payers can, come in and knocking at the door to Dr. Andy's clinic, hey, we need, 150 charge, on your patients. We're streamlining that, working with them on that secure transfer of information, really taking the burden away. And so they can focus on really seeing the patients that they need to see.
Yeah, I just want to piggyback on what Justin said. From the CMS perspective, we can't overemphasize the importance of cooperation and collaboration among these HIEs, RDAs, and payers. It's the great work that SHARE and Arkansas Blue Cross Blue Shield are doing among very many other regions is fantastic, and we're always looking to build that collaboration and partnership in all these PCF regions. It makes it easier for the practices and the payers alike to get better outcomes for the patients, right? It's we're always trying to understand what the secret sauce is. Why some regions have better collaboration and cooperation, and maybe some and others are overcoming some barriers. But from, I guess, the bigger macro perspective, CMS is always looking to improve partnerships.
Yeah,
Thanks.
partnerships are key.
Thanks, James and Justin. I did see quite a few questions in the chat around availability of HIEs, how practices can connect to HIEs, where CMS is participating in data aggregation. So I can cover a few of those quickly. We did provide a couple of resources in the chat, and we can provide those afterwards as well, which provide some information about how you can find and connect to your local HIE to find out about what types of services are available to you. There is some variation depending on the region and the HIEs and what use cases they can and cannot deliver. Currently, CMS is participating in a handful of the PCF regions, not all of them. And that's really based on multiple factors, the readiness of the HIEs to be able to ingest that CMS data and integrate that into the use cases that CMS has prioritized for the model. But we're always interested in hearing more from your practices about what they're interested in. And as you read through those use cases, if there are any questions that you have, please do feel free to reach out. Jen from CyncHealth, do you want to talk a little bit about, if practices in Nebraska are interested, what they can do to learn more?
So they can absolutely just look us up online, cynchealth.org, or they can reach out to me. And I'm assuming some of our speaker information might be available in some format. And then I would put them in touch with typically our account management team that kind of goes over like, this is the process to get started.
Great. And Justin, maybe from your perspective in Arkansas or other HIEs that you're aware of, any best practices for our PCF practices as they try to connect and learn more?
Yeah, I think, piggyback on what James said, I think collaboration is key, and being open to what are your needs at your practice, how the HIE can be a strategy on assisting you in delivering ENS notifications. I heard one practice, I've been at the HIE for 10 years now, and they said, oh, no, I know I get the report from a local hospital on my patients. And, fast forward, they realize that their patients are very mobile, right? They're mobile. They do not go to one hospital. They do not stay in one county. So really, I think, health information exchanges are that data utility that can be able to assist practices and empowering them with the data so we can reduce redundant tests and pushing that information to where they need to go. Most states have an HIE. In Arkansas, we're very fortunate to be that statewide HIE, just like Sync in Nebraska and Iowa. It kind of really, it assists us in a lot, and we're part of the Arkansas Department of Health, so it helps us on that as well. But definitely reach out to your local HIE. They're a resource. There's so many different services and products that can be available to assist you in your value-based program. And then anyone, I saw multiple of my practices on this call, if you know how to get in contact with me, but share health@arkansas.gov is our email that goes to me and several others. But you can go to sharearkansas.com and be able to see who's connected, kind of success stories, and just a little bit about our services. So it's been great.
Thanks, Justin. And sort of piggybacking off that comment around patients being mobile and receiving care from other settings, can you just talk in the last minute that we have here about really the added value of what's not in a practice's EHR and what they really could be missing if they don't participate with an HIE?
Sure. With Share, we're connected to over 65 different electronic medical record systems, right? So that is a lot of different data that doesn't go into the top 2 or 3 EMRs throughout the nation. So patients, travel, like the boss said, they may go to the endocrinologist, 2-3 hours away. They are going to their level 1 hospital here in Little Rock, where Mountain View is about 2 hours away. 2 different EMRs. Her local hospital is on a separate EMR. And the HIE is a data aggregator that allows for that normalization of that data and empowering the practice with those lab results, the latest and greatest A1Cs, social needs, discharge summaries, so they can be proactive in reaching out to the practice. And one thing that I get a lot from practices, the clinical data is great and we use it. But if we can't get a hold of our patient because the phone number changed, the address changed, the HIE is constantly updating that within the infrastructure. So it empowers the practice to have the latest and greatest phone number, address, so they can be in touch with that patient in more real time than it lagging, So I think, it's a resource, it's a tool, and most states have an HIE, and I encourage you to reach out to them.
Thanks so much, Justin, and thanks to all of our presenters as well as all of our participants in the audience. We hope that you've enjoyed this session today. We have shared resources in the chat, and there's also a resource slide where you can access those links as well. Thank you all again. You will be receiving a closing poll that'll launch shortly, and we encourage you to complete that as well. Thanks so much. Take care.
Thank you.